To review today's agenda. And if it's your first time with us, we'd love to meet you. So please put your name and where you're from in the chat. We're very fortunate to have our own hub team member, Karen Hayes, who's going to present her didactic today on aggressive behavior and violence and dementia, caregiver and law enforcement perspectives. Sorry about that. And then we're going to have a couple of case vignettes and hoping for a really engaged discussion with the community to learn together. Please, if you can, rename yourself with your first and last name and the clinic that you're joining from. When you're not speaking, please mute your microphone. And if you can, turn your camera on. If there's more than one person in the room, then put them in the chat as well. There's CME from University of Washington. If you're faculty, staff, or student, to register, send your email address to this 833-394-7074. And then you should receive a message saying that you've registered. If not, you can sign into this uwcme.org. After registration, then text 10085 to that number, and you should receive the response thanking you for and having recorded your attendance. For all other attendees, Sammy is recording your attendance, and also it's being recorded through Zoom Analytics. Therefore, it's really important that you display your full name. And if there's things that Sammy needs to clarify, she'll reach out to you. There are a wealth of other ECHO programs through the University of Washington, including in geriatrics, in traumatic brain injury and behavioral health, in psychiatry and addiction, as well as a telebehavioral health training series. There's also a telephone consultation line for complex pain medication management, especially for those on high-dose opioids here, and also a CME accredited case conference, the UW Telepain series. In addition, there's fantastic grand rounds, both from neurology and psychiatry, which are available via Zoom and also through an archive, as you see here and here, CME accredited as well. There's an upcoming, our second Healthy Aging Summit. Our first was at the Greenwood Community Center. The second is this year on April 18th at the Mercer Island Community Center. This is really for people who are living with cognitive health challenges and their care partners and anyone they want to bring along. It's free. Mary Grace Becker is actually giving the plenary about dementia friendly communities. There's a series of talks and then some interactive breakout sessions. So you can share with your patients if you'd like. And then please do consider bringing your cases to this format to ECHO. As we've said on a number of occasions, no case is, too small or too complex. We learn from each and every case. So reach out to Sammy if you have a case to present, and we can help you also to put it together if that would be helpful or useful. And then as you see here on the right, after you've brought forth your case, we create this. We take all of the information, everything that was discussed during the case presentation, and then after in a discussion with our hub members and generate a list of recommendations. And then Chris Rhodes and I are available to consult as well. So we hope that it's useful to you. And then when you are presenting a case, protect PHI. Please don't say anything that could reveal any personal information. All of our sessions are recorded and available on the website, and it is through your feedback and input with the very brief 1-minute post session survey that we can improve upon these gatherings, our ECHO meetings. As we said, there's CME through the University of Washington. Nobody has any financial relationships to disclose. None of the planning committee nor the presenter. Here's our hub team. We really represent a broad, multiple health systems, the Dementia Action Collaborative. So we're very proud to have this kind of broad representation throughout different health systems in the DAC. We're also very happy that we continue to grow throughout the state of Washington, and through your sharing of the value of this with your colleagues and others. We've provided over 1,700 instructional hours since we began in June 2020. In 2023, 100% of respondents reported Project Echo Dementia improved their quality of care for patients with dementia. We're currently serving 96 sites with over 250 zip codes, 43 providers, and we really do just want to keep growing to build this capacity to care for people living with cognitive health challenges and dementia and their care partners in the state of Washington. So we will have kind of a more of a related case presentation with after the didactic with Karen Hayes. So without further ado, I am very pleased to introduce Dr. Karen Hayes, who, as I said, is a hub team member and a care partner of a person who was living with dementia. And she's going to talk with us today about aggressive behavior and violence in dementia from her perspective as a caregiver, and also bringing in law enforcement perspectives as well. And thank you so much, Karen, for this talk. And I will stop my share. And please share your screen.
Unmute. All right, are we good visually? Great, you can hear me? Thumbs up, I love it. All right, hi everybody. Sorry, I'm gonna minimize everybody's beautiful faces here. Okay. All right, thanks for allowing me to talk about this topic. It's not an easy topic, but increasingly in my dementia caregiver support groups, I hear about episodes like this, so I want to understand it better and also have personal experience with this. So that brings me to this topic, and the law enforcement piece is quite new to me, and so I did several informal interviews with folks in law enforcement to kind of see where they're coming from when it comes to this. So now I need to advance my slides, but it's not, I guess I'll have to do it with my mouse. Okay, here we go. So like I said, I did experience this the last 6 months or so that my husband was alive. He died almost 2 years ago with a presumptive Lewy body diagnosis. On autopsy, it turns out he had Lewy body and Alzheimer's and vascular dementia. And so we did the dementia journey for about 8 years together. And he's sweet, lovely, wonderful man his whole life. And then after his very first COVID infection at the end of 2022, his brain just changed and his personality changed quite a bit. And he got quite agitated and aggressive, so much so that I had to put him in a memory care place. And then he, on day 4, proceeded to try to kill everybody in the memory care place. So he ended up in the emergency department, geropsych, for 7 weeks. And then needed quite a bit of medication and died 5 weeks after he was discharged from the geropsych. And this all, I'm a very planned person. I'm a nurse. I'm a disaster responder. Planning, looking around corners was always my my forte, I thought, but this caught me completely off guard. So I'm still trying to make sense of it. So it was great to have an opportunity to do this literature review. And that second quote here on this page, from a qualitative study, an unavoidable situation that seems impossible to solve. That really rings true with how I felt at the time and how a lot of my friends in my dementia support groups feel when this starts visiting their household. And so I hope this 40-minute talk can help move the needle on making it seem less impossible to solve. So first, we'll talk about terminology. I'm going to use PWD for person with dementia, but sometimes you'll see care recipient as well. That's used in the literature, I noticed. And then persons living with dementia is also another acronym that it seems to be gaining popularity. I'll talk about caregivers. We talk about care partners as well, but to tell you the truth, in my caregiver support groups, I've asked people about this, and people like the term caregiver because it has the word give in it. And we all feel like we're giving so much of ourselves that it keeps daylighting what that experience is for us. So I'm going to use the term caregiver. The literature talks a lot about informal versus formal caregivers. I think it's a little more explanatory to talk about family, even though it could be a friend, but family versus professional. Professionals, of course, are usually paid. It's part of a job, and family caregivers are usually unpaid. And they're just doing it because that's, well, multiple reasons, and we'll kind of get into that more. You all know the phrases or the acronyms BPSD and NPS, and I'm not 100% sure if those are conceptually equivalent or if there are some differences. Somebody who's on the Zoom here maybe knows a little bit more about that. Not too important, but those get used interchangeably in the literature, so there they are. And then of the subset of those that has to do with agitation, aggression, violence, and what's often called abuse, a little bit controversial term, but basically definition, everybody defines it differently in their first paragraph of their research studies. But basically, it's the actual attempted or threatened harmful verbal or physical contact towards caregivers or property by the care recipients. And this causes fear and a feeling of danger in the caregiver. At the beginning of these talks, people always talk about incidence and prevalence, and we can't really do that because it's not well documented, well measured. So we don't know. In the studies that I read, the range was anywhere from 20% to 75%, and that's likely very much due to, what their sampling frame was and who they were looking at. So on that theme of trying to measure this stuff and define it, the International Psychogeriatric Association, IPA, in 2015 came out with a preliminary definition for agitation and aggression. And just last year, they took away the word preliminary, and now it's actually official. And they want all clinicians and researchers to be aware of this and to start using consistent terms so that this stuff can be tracked and measured in a way that helps people do meta-analyses and systematic reviews and so forth. So basically, they've got three parts of this: excessive motor activity, known as agitation, which has to be distressed. Before they just said restless, pacing, rocking, etc., but they added the word distressed. There's verbal aggression and there's physical aggression. The previous definition said this had to be going on for at least 2 weeks of impairing relationship sociability, or the ADLs. But then they added if it comes on suddenly and dramatically, that also can count. You can also call this aggression or agitation due to the dementia illness, which requires a little bit of finessing to make sure it's not because of some underlying psychiatric or medical condition. And then the last two notations on this slide, the NPI and the Cohen-Mansfield, seem to be the two tools that are used to measure agitation and aggression. And I think the NPI was a little bit better than the Cohen-Mansfield in being aligned with the IPA definitions. But if you're interested in this stuff, see the recent article by Wong and colleagues, and they compared 9 different tools for measuring this stuff. Really interesting article. So before we leave the vocabulary domain, I just want to talk a little bit about a couple articles that I found really interesting about communication disconnect between the caregiver and clinicians. And these researchers discovered that, no big surprise, but caregivers thought about it and referred to the behaviors differently than clinicians do. We tend to say things like agitation. I say we because I'm a nurse practitioner, but I'm going to take that hat off and just be a caregiver. Clinicians tend to talk about things like agitation, altered thoughts, aggression, apathy, and those phrases don't necessarily fit into the vernacular of a lot of caregiving families. So if you are doing a history and say, oh, has the person been aggressive? Has the person been agitated? They might not know what that means. And so these researchers in their recommendations were to try to ask questions that use the words that your clients would use, saying, have the person been upset or frantic? Or having a meltdown? Has the person been flying off the handle? Have they been hurting you or being unexpectedly angry? Asking questions like that. Again, this hasn't been tested, but that was their recommendation, is to really get down into what those behaviors look like in the home setting. Oh, and before the last bullet point, they said, oh, some of these terms can be stigmatizing, but then they didn't go on and say which one. So I'm just going to throw that out there and just know that that maybe something will be coming down the pike where we might be having to change some of this list of symptoms. Okay, the pathophysiology, super fascinating. Most of it I don't understand, but I wanted to put it in the slide deck because in case this is your jam and you know what all these bullet points mean, great. This is a summary. The first one, the neurobiological correlates, really good. The work by Gill et al. It's really enlightening. And then the cerebral blood flow study I also found was very interesting. And I noticed in several articles, they talk about early versus late onset of the behaviors, and those might actually be neuropathologically distinct. So that doesn't mean anything to the caregiver who's being the recipient of these behaviors. But I think going forward, it's going to be interesting to see if those need to be approached differently and managed differently. So of course, it wouldn't be an echo dementia talk without showing a picture of a brain. So here's my brain picture. And again, I don't know all these different parts of the brain and what they do and so forth. I'm sure the people on this call know much better than me. Of course, I know the amygdala because that's such a big favorite in dementia. But the pull-out point I wanted to make was that agitation and aggression can present early in the disease course, and that tends to have a poor prognosis. And especially if it's younger onset dementia, it is more dangerous for the caregivers because now you've got somebody who's actually more physically robust, able to ambulate, able to overpower, as opposed to somebody who's in late stage dementia where they're no longer walking and so forth. Although we know some of these frail people can pack a real punch when they get upset. So it doesn't mean to say that they're not also capable of hurting somebody, but definitely the younger onset dementia, just something to keep in mind if you're seeing clients like that. All right, so let's dig into the literature a bit. So violence in families. These two articles I really enjoyed. They're very much worth reading. But I got to the end of them and didn't see the caregivers in there. This one by Warren, extensive scoping review, 48 articles, where the researcher came up with a conceptual framework that there's 5 distinct types of violence in family settings. And they had elder abuse in there, but as we know, that's different. That's the caregiver abusing the person who is needing to receive care. So I actually contacted Warren. They live in Australia, and we had a nice email exchange about this, that maybe a 6th category needs to be added. And then the Shepard-Bannigan article is VA, nice big survey, 1,500 people. 45% of the vets had dementia, 45% had PTSD, and caregiving was rated mostly as high intensity. So they measured lots of things, the experiences of the caregivers and so forth, but I didn't see anything about aggressive or violent behaviors in there, which I thought was interesting because these are vets, PTSD, and what I hear in my support groups The wives and husbands of veterans do experience actually quite a bit more violence than the rest of us who married non-vets. So I think this is an under-researched area of this phenomenon. So Isham and colleagues, it's published an article in 2019, which I highly recommend. They looked at studies that looked at about family violence, and they also looked at studies about aggression and violence that happens in all kinds of illnesses, not just dementia. And they ended up with this Venn diagram, sort of parsing out what the concepts and the constructs were and seeing where they overlapped. So that was some good foundational work that they were doing. And of course, I tried to look for articles with aggression towards family caregivers with dementia, and that was difficult to find. Most of the articles are about caring for, oh, quote, older adults, some of whom have dementia, but not all of them. And so what I have to report to you is not real clean in that respect, but I still think it's relevant to the caregiver experience, regardless of why the person that they're caring for is being aggressive with them. It hits real hard in lots of different ways, figuratively and literally, for the caregiver. So I think these are worth talking about. So I'm not going to go through all these details. You can look at the slides after they get posted in a few days if you want to go through all of these things. But the von Humboldt study of almost 400 family caregivers from Brazil, the UK, and Portugal, high rates of verbal violence and emotional outbursts. About a third experienced physical violence, and almost a third with some kind of sexual violence or abuse. And of course, caregiver mental health went downhill with all of that experience. And I just pulled out some quotes which kind of spoke to me and hopefully give you an idea of what caregivers are saying about their lived experience. And a couple I'll just read out loud. The first one here: "It's disheartening when caregiving takes a toll on one's sense of safety." And then the last one there: "It makes me angry that I can't provide the care they need without endangering myself or others." Another study, now this is the same one, Isham et al., that did the Venn diagram. And I like this quote from them: "To what extent is violence or abusive behavior an extension of caregiver burden? Is it a form of domestic abuse or harm? The issues of vulnerability are blurred." And I think as we go through the literature, you'll see it's really not well teased out, both in the medical realm and also in the law enforcement realm. So this review of 18 English language articles, again, I'm not going to read the whole slide, but I just want to point out that I really appreciated in their discussion when they said the caregiver needs to be seen through a lens of trauma. And I think all of us healthcare providers have had trauma-informed care, some kind of education on that. And I appreciated that. And I hadn't ever thought of that when I was actually being an active caregiver. But I think that would have helped me a lot. And then I'll just read this last quote from their article. "A release from responsibility due to the disease shifts attention from the person carrying out the behavior to a critical focus on the caregiver. Are they caring in the best or right way? Do they understand the illness well enough?" And I have two minds about statements like this because it's a slippery slope or it's thin ice, whatever metaphor we want to use. Because obviously caregivers need education, need training, all that kind of stuff. But also this could easily morph into a blame the caregiver, that the person's getting agitated and aggressive because the caregiver is failing in some way. And that gets pretty dicey in terms of trying to support a caregiver when they're getting the feeling that that's the lens they're being seen through. And then I thought about it more when I read Isham's 2020 article, where they called this a hidden problem. And I'll read that last quote. "In some ways, this is domestic abuse, but it's also very different. My husband can't help how he is. I need to be able to help my husband and to stay with him." So this is a situation where caregiver is being harmed emotionally, maybe physically, and suffering mental health breakdown sometimes, but this is our family member and we have an obligation. And I also appreciated this concept in the middle of the slide here, the last bullet point: epistemic injustice. It's actually a PhD dissertation by a person named Miranda Fricker, and I read this like 6 or 7 years ago. I actually ordered it from the college because I was really intrigued with the sexism and racism angle of it. I was in academia then and really researching this stuff. But now, as a caregiver, also experiencing some epistemic injustice, which is that one's experience, you try to tell people, you try to share it, but people don't see you as credible or believable. And so your experience is obscured because it cannot be seen or it is not seen. And so it's just a fascinating concept, which I'm probably philosophers and psychologists and sociologists could get into this much better than I can explain it. But having had read the paper and then seeing it in this article, I was just like, oh my God, it's all coming together. All right, so this article kind of surprised me, came out of nowhere, but it's a great article. They used Alzheimer's Disease Research Center data, which just pulls from all across the United States, case control study of married partners who separated or divorced after the index date, after they were enrolled. And it was found, to their surprise, that divorce was more common in earlier stages of the disease. And they hypothesized that maybe later stages, the spouses are more forgiving because the person is clearly more sick and ailing. Or perhaps the marital relationship is already dissolved over the years of caregiving and the person not being able to be a mutual spouse anymore. So your expectations of your marriage just aren't what they used to be or what we think they should be. The till death do us part, obviously a lot of people take that seriously, but also that death part is getting closer when people are getting later in their disease. Or, as we know, with domestic violence, intimate personal violence, people sometimes can't leave a situation because of finances. So you end up staying. So these stars I put on there just to point out that agitation and aggression, and also depression and dysphoria, the disinhibition and elation, those were all significant on this plotting diagram, and that agitation and aggression and the depression, dysphoria had fairly tight confidence intervals. So if you're interested in uh, sort of talking about this kind of thing with your newly diagnosed couples who have MCI or early dementia, it'd be good to kind of know some of this stuff. And particularly, I want to point out Othello syndrome, which is the delusional jealousy. These articles pointed out could be an early sign of dementia, might be the first sign of dementia, people getting divorced because all of a sudden somebody's accusing somebody of having an affair and it's getting physical at home with the anger. And it's most of the articles I saw about this had to do with Parkinson's patients. And it's well documented that the dopamine agonists can bring this on, and weaning people off of those can actually reverse it sometimes. So it's good for all you clinicians to be aware of that. So I expanded my search to look at aggression towards paid caregivers, even though I was focusing on family caregivers. I think what happens to professional caregivers has some generalizability to, because you're caregiving, you're fond of somebody, you're in their personal space, helping them with their daily personal needs. And if you're verbally or physically attacked by trying to do that, that's pretty disheartening. So all of these articles that I found, it's not surprising that people had lower job satisfaction when this was going on. But still, it was enlightening to hear some of their quotes, like the one I have in purple here. You really have to care for them against their wishes. And that's true. The stuff has to get done, and they don't always want you to be doing that. And sometimes it's hard to find the peaceful path. And the Chanelli article, excuse me, I found it quite shocking. Out of over 800 professional home caregivers in Switzerland, the aides and the nursing assistants, who we know do most of the custodial care, which is often the trigger for agitation and aggression, they didn't receive any training in aggression. Only the nurses got the training. So I thought that was a point to be reversed in the future. And then the caregivers acknowledged the lack of backup in the home setting, and they felt angry when they weren't supported by their employer. And that also came home to me reading some other articles. This Kang, the couple of Kang groups, they're from South Korea and have done some systematic reviews on this issue. And I just thought about, these are about paid caregivers who are employed by an agency with coworkers, they've got supervisors, they are supposed to get some training. If they have a problem with a client, they can get reassigned, or if they get hurt from a client, they can take paid sick leave, and none of this is available to home caregivers. Home family caregivers are doing the vast majority of caregiving around the world for people with dementia who are living in the community. But we don't have any of this. So triggers, super important to understand these, and everybody's going to be unique. I liked this quote: "The onset of physical aggression in dementia patients can be very dangerous for caregivers. It's often an unexpected attack." And that idea of it being unexpected was really demoralizing to both the paid caregivers and the family caregivers. But everybody recognizes the person with dementia is trying to communicate needs or feelings, and they can't get that out, and sometimes they get so frustrated that they just erupt. Nonetheless, these triggers happen again and again and again. Some are not controllable. I'm not going to read the list here. You can look at all that. But I did want to point out the last couple about the caregivers. And again, this is that slippery slope, that thin ice. But it's also true that caregiver attitude and approach can provoke aggression. If you're authoritarian, if you're handling roughly, one of the articles said bossy or nagging, people with dementia, well, nobody appreciates that. And people with dementia can be particularly unhappy when they're approached like that. And the other bullet point there, the caregiver doesn't recognize the discomfort, frustration, or anger early enough to avoid or to de-escalate in time. And that was something I learned in dealing with my husband, that if I could catch him early, if he would grab my wrist or I could see his face starting to screw up in anger, I had some ready-made things to say or things to do to kind of snap him out of it. And I was kind of shocked at how magical that was. One of ours, we used to watch Seinfeld, and there's a phrase in there, "You're so good looking." They say that after somebody sneezes. And we used to laugh about that for years in our marriage. And I'd see his face get screwed up. He's getting super frustrated with me. And I'd say, "You know what, honey?" He'd say, "What?" I'd say, "You're so good looking." And he'd smile. He'd say, "Really?" And he liked that. And it just nipped it in the bud. It was really amazing. Now, eventually got to the point where that didn't work, but it did work for several months. And we'll talk a little bit about some more ways to avoid those triggers here in a few minutes. I did want to cover about why caregivers don't report. We have a lot of people saying this is a hidden problem, it's not recognized, it's not addressed. I talked about this epistemic injustice. And why don't we report? I didn't really tell that many people what was happening. And a few times when I did try to tell, people just couldn't believe me because my husband was so sweet. Everybody knew him for decades, and he's just the greatest guy. And they couldn't conceptualize that, and they weren't living with us to actually witness it. And so this quote I threw up there that I thought was a good one. "There's no choice but to tolerate it, to cope with it as the only moral and pragmatic option." Again, you're in the family, you are there because of family obligation, loyalty, love, duty, etc. And so you stick with it, and you put up with stuff that in a regular relationship or in a workplace or something, you would never put up with that kind of behavior. But people do when it comes to dementia. And so here's a whole list of reasons caregivers don't report. As you look through them, that you might recognize, oh, this sounds like the work on domestic violence or intimate partner violence. Again, because it's in families, and it's happening in families, it's happening behind closed doors. Often the face given to friends and neighbors and coworkers is really different than what's happening inside the house. And that sort of way of being just continues into this household that has had this illness in it now. So there's a couple at the bottom, again, about caregivers, which I thought was interesting. Caregivers risk being blamed, again, for being bad or unskilled or uncaring or letting things get out of hand. It's their fault, the agitation and the aggression is happening. And then I also had to acknowledge, sometimes the caregiver, there is elder abuse. Sometimes the caregivers are actually abusing the person and they might be fighting back. And so if the caregiver reported, that might expose their own behaviors. And so again, the more you dig into this, the more murky and it starts to get. But if we don't dive into this, we're never going to be able to solve anything. We can't stay superficial with this. We've got to figure out what's going on so we can really help people. Which will bring us to dangerous situations. I talked to several law enforcement officers, police and sheriff, to get their idea about this. And they were all pretty the same in what they told me. That caregiver safety always comes first. And I'll tell you 100% of the time, caregivers will not put their safety first. We get so used to putting our safety and our well-being secondary to the needs of the person with dementia that even when it comes to physical violence, it's hard to flip yourself out of that. However, having said that, I do hear lots of stories where caregivers have had to lock themselves in a room for hours. Sometimes they've had to leave the house because the person with dementia is just so incredibly violent. And of course, got to call 911. They're expecting these kinds of calls. I never called 911. It didn't occur to me. I just thought, well, 911, that's for criminals and stuff. And my husband wasn't a criminal. And so I never called 911 when he's been, I called some friends to try and come and help me, and with variable success. But at any rate, when you call 911, you should absolutely, and this is, you can teach your caregiver patients about this. They absolutely need to mention that the person who's out of control has dementia. And definitely the police need to know if there's a weapon involved. And also you should report if you or anybody else is injured, because then EMS can be activated immediately. And ideally there's a key hidden, because if EMS or police ever need to get in, it's much better for them to use a key and walk in nice and calmly instead of like banging on the door and kicking the door and like we see in the movies and stuff. So having an outside key hidden somewhere for them would be super, super helpful. And then oftentimes after a situation like this, a trip to the emergency department is indicated because they need full medical and well, for sure medical. They don't always get psychiatric assessment, and they might need some chemical restraint with some medications. And the advice is the usual thing: bring the medications list, et cetera, et cetera. And then this is an area that I'm starting to get into now that I've been through all this. I'm being asked to counsel some people who are also experiencing this, and what was told to me by friends and what I tell other people is do not accept that person with dementia back into your home if they've started to become physically violent without getting a proper psych evaluation. And you have to push for this. So as primary care providers, I encourage you to be the support person to the caregiver, and even make yourself available or somebody in your practice that they can call from the ER to help get support. Because if the person comes back home, it's just going to continue happening, and it could happen to a point where something really horrible happens. And so the emergency department needs to take this seriously and not just, turf them out, got to get them out, clear the bed for the next patient. You've really got to stand your ground. And that's what I ended up doing when my husband ended up in the emergency department. Nothing was wrong with him physically. And by the time he got there, he was like, oh, happy again. It's super nice, even though an hour before he was trying to kill everybody. So they didn't see the problem. And so, of course, request that a social worker comes. And what happened with me and what I've learned about since is about, if the county that you're in has a county mental health crisis team, they can be dispatched to do an assessment. And if they need to have an involuntary commitment to a geropsych, then that has to happen. They actually come under the auspices of the court. I no longer was the power of attorney. I was a witness. And my husband was under the court jurisdiction for the 7 weeks that he was in geropsych. And now in hindsight, like that was totally appropriate and totally great, but I didn't know any of this, didn't know how to advocate for any of it. But the social worker was my angel. and really turned the whole situation around for me. I mean, if they had discharged him, the memory care place wasn't going to take him back. And everybody's saying, you can't put him in, you can't take him to your house. I was like, well, what am I supposed to do? Like put him under a bridge on I-5? Like, what is the situation here? And the social worker knew exactly what to do. All right, so this gets us into criminal justice system a little bit. So this article by Gold, 2023, super long, like all law review articles are. Really interesting, kind of depressing if you're a law enforcement person. It might feel a little accusatory, but basically the article is talking about a bunch of cases that went bad and wrong, where police were interfacing with people who had dementia. And this quote, I thought, really summed it up well. Dementia leads people to engage in activity that appears criminal. If you don't know they have dementia, it looks like they maybe are, on substances, or they have a mental health problem and they're out of control, or they're just a bad person, yelling and swearing at people. And so if they don't know they have dementia, they don't treat them like they have dementia. So police have misread confusion for defiance and then used excessive force. And if you read the article, there's these terrible stories about tasing and shooting and breaking arms and all kinds of stuff. And this also, just like the Othello syndrome, this also struck me. Sometimes criminal behavior is the first sign that something is wrong. And I had never thought of it that way. And that's something, if you have a middle-aged or older person who's all of a sudden getting in trouble with law enforcement and criminal justice system, that might be a cognitive illness that they're brewing. So be alert to that. So again, the Goal article described all these tragic cases, and some of the take homes that I got from this was that the police don't track the encounters they have with people with dementia. So there's no database where you can start looking at these things easily. You'll see, I'm going to talk about a study from Australia where they actually did this, but it was a lot of work to try to find out the incidence of this. Another thing that's really obvious from reading all of these cases that have happened in real life is that, as we know, people with dementia need slow, repetitive communication with an easy mood, super nice and supportive. They need time to process what's happening, especially if they're in an unfamiliar environment. But the police, they get a call and they hear there's a weapon and somebody's in danger, and they come in ready to disarm that person and keep the public safety. So they're trained to speed up, speed, speed, speed. So this is obviously a collision course for things to go wrong. So I think this is worth thinking about why this goes so bad so many times. I also, reading a lot of these cases, the early and even moderate dementia can be masked. When you see somebody walking down the street, you don't necessarily know. You see somebody in a house who looks reasonably normal, but they're being violent or they're being super aggressive, out of control. You don't necessarily know that that's from dementia because they're not looking all frail in a wheelchair. And so officers often misjudge what they're seeing. Even neighbors, and especially if it's all been secret, the neighbors don't even know that the person has dementia. And then the other thing that's frustrating for caregivers is we call people, oh, he's freaking out. He's grabbing me, he's choking me. And then by the time your friend or the police get there, the person can be in a totally normal mood. Like I was mentioning with my husband, joking, laughing. They don't remember what they did. And so as the caregiver, you're put in a really awkward situation. Like, no, I swear, 10 minutes ago, he had his hands around my neck. So that's frustrating. And also it's miscommunication. So in the criminal justice system, again, read the article if you're interested in this stuff. But they said charges are usually dropped when the dementia diagnosis is eventually discovered. So yes, they've committed a criminal activity, but because of the dementia, they get a pass. But the courts and the criminal law scholars, they really haven't figured this out. The forensic psychology, my niece is a forensic psychologist, and it doesn't really, it hasn't been validated for people who have dementia. So this is a big gap in both our medical and our criminal justice systems. So law enforcement, this article is the one from Australia I mentioned from last year. And believe it or not, they went over 400,000 plus police narratives. I don't know if they had some AI program or something, but anyway, they read all these police narratives and they found 260 calls over 10 years that involve people with dementia being violent against their caregiver. And I just pulled out some of the stats that were of interest. So 50% of them were assault. Obviously, police are getting called because something physical is happening. They don't always get called just for verbal abuse. And sorry about the words on these slides, like the word victim and perpetrator. Those are the police words, and I just used them to be true to the research. But we don't talk like that as clinicians, but that's police talk. And the injuries, you can look at the injury types. There were 85 injuries, and they were mostly mild, cuts and bruises and swelling and so forth. But notice at the last line in the abuse type was there was actually one homicide. And so that just should make you sit up and take notice that homicide can actually happen in this situation. So more about law enforcement. This article is from San Francisco over 10 years ago, but I liked it. It was 141 police officers who did a questionnaire, and then some of them were interviewed. And they were talking about, this wasn't specific to dementia, but about responding to older adults. And only about a third of them rated themselves as knowledgeable about age-related medical and social issues. And the common reasons they were called to older adults were, of course, medical emergency, suspected criminal activity, and welfare checks. And they did note that paranoia, agitation, and aggression are common on these calls. And I liked this quote because it really sums it up. We're police officers. We're not doctors or psychologists. But nonetheless, the police officers identified themselves as playing a role in the healthcare system. And that was a new way for me to think about it. But they are first on scene, and they're seeing people actually in their homes with their families. I'm also a volunteer EMT. We get to see things that the clinician in the clinic never gets to see, to really kind of know what might be going on in the home. And the police want to know what the medical and social services are, and are happy to refer people, happy to link people up. They see that as one of their roles. So I really like this article to make it seem like, oh yeah, we're not just two professions that are completely distinct. There is some overlap, and there should be some coordination. Speaking of which, lots of examples of this across the nation. I pulled out a few to talk about. So alternatives to sending police when you've got a situation where someone with dementia is being agitated or aggressive. The Phoenix system is to have a crisis line for immediate counseling. The dispatcher, as soon as the dispatcher hears that somebody with dementia is out of control, whatever, they immediately get 24/7. There's somebody to patch in to the person who's calling 911 to start counseling them. And I love that idea. And then the goal article, the law review article, talked about CAHOOTS. I forget what it stands for, but it's been around for 30 years in Eugene. So yay, Eugene. They've got a medic and a behavioral health crisis worker who respond to whatever the dispatcher figures out is a mental health or a behavioral health problem. And I love this statistic. In 2019, there were 24,000 calls to this CAHOOTS group, and only 150 of those needed police. So if this isn't evidence for appropriate use of resources and not wasting police time on things where they're not needed, and actually having the right kind of assistance come to a home, like a medic and a behavioral health person, I just thought that was fantastic, and more people need to know about this and use this data to get some grants. The STAR program in Denver started only about 5 years ago, and I appreciated them emphasizing the expert training in danger assessment and de-escalation, because that's what it's all about for police and for EMS and for behavioral health crisis workers that are entering these situations. And then our own Dr. Kimi and Dr. Chris from Echo Dementia have a project going on to get clinicians and law enforcement folks collaborating on how to better support people with dementia in the community. So I'm looking forward to hearing from both of them in the future to find out what they have discovered so far and where this is going to go, because this is going to benefit all of us in Washington State. All right, just a little bit more about law enforcement. The dementia registries are becoming more popular. They started for people with dementia who go wandering They elope from home or wherever, and they need to be found. So of course 911 is called, search and rescue. But if the person is already registered, they can review this information on the way to the call and better know where to look for them, for one thing, or if it's somebody who's not missing, but is running amok in some other way, they can learn a little bit more about them, what they like to be called, and da da da. And these purple arrows I put on this form that people can fill out is about officer safety, because obviously they're very much all about safety appropriately. And that's just super great stuff to have so that we don't end up with some of these tragic stories like in that law review article. Now, there are barriers to participation, particularly social stigma and distrust of law enforcement by some people in some communities, and obviously protection of personal health information. But the two references I put at the bottom of the page, those are monographs, tons of super specific information and examples of how you can implement this in your own community, taking all those considerations to heart. So got to talk about firearm safety, and I just couldn't put a picture of a gun on my slide. So instead I have this gentleman holding his slipper. He's gonna whack somebody with his slipper. But imagine if he was holding a gun. That changes the tenor of the encounter a lot. And we're in America, so I only looked at American-based references because we have our own unique gun culture here in this country. And these 4 articles I thought were really good and current because we all need to be doing firearms assessments and counseling with our clients and with our friends and family. And this statistic just blew me out of the water, that 60% of households where somebody's living with dementia has a firearm, and only 16% of them are storing them in a safe manner. So there's a lot of work that needs to be done on this topic. All right, the last section of my talk is management of these behaviors. And I came across this pyramid developed by Brodaddy et al. More than 20 years ago. And then it didn't seem to get a lot of play, at least in the literature that I was looking at. And then Munchendani and Conrad resurrected it. And they're in an inpatient psych unit where people have dementia sometimes. And so they were using it to try to classify them and see if this thing actually worked. And they had some troubles with it, but still, I think it's useful if you want to look at, the bottom tier. I know this is super small print, so I apologize for that, but you can pull up the article and look at it. From no dementia to super extreme behavioral physical violence problems. And the pyramid lists what kind of signs and symptoms you might see, and then also what kind of management, what level of healthcare worker needs to be, or professional needs to be involved in their care. So that's just for you if this might be of interest for writing your protocols or your algorithms or whatnot. Another couple articles I want to refer you to, the Anderson article. These researchers looked at blogs by family caregivers, and they did the themes out of that, which of course I love because that's the caregiver voice. So I really recommend you look at that article. And then the Watt article is a recent publication of guidelines and recommendations on these kinds of behaviors. And then, of course, we have 2 recent echo dementia presentations, one in 2022 and one just about a year ago, about these kinds of behaviors. And these are just a couple of screenshots from the Xantop talk. So if you want to get, I'm not going to go into this, and not being a dementia provider, I don't feel like I should be teaching this kind of stuff. But go ahead and look at these talks because they're fantastic, everything you need to know. And the last thing I'll say about, no, second to last thing, good things and good ideas and advice for caregivers and clinicians. The Cummings article is great. It's about the family home, but also nursing homes, emergency departments, and hospice. Of these 5, I would say go to that one first for more advice about ways to non-pharmacologically manage these kinds of aggressive behaviors. So the last thing I'm going to say is the pro tip, and I'm surprised I don't see more of this, but like I talked about with my husband, by being able to recognize the situation that was unfolding and putting it in reverse, that was a real skill that I enjoyed and developed, and I think it kept us together at home for a lot longer than it would have otherwise if I hadn't have known, if I started arguing with him or trying to control him or be the boss. I think things would have got a lot worse a lot sooner. So basically, if you're familiar with the person that you're taking care of and you recognize their tells, you can sometimes, not always, again, we're not going to blame the caregiver, but sometimes you can nip the aggression in the bud. And for me, flattery worked. In my very first dementia caregiver support group, which our own Dr. Rhodes was the facilitator in that. One of the participants talked about volcano presence, and she said that when her partner like will just fly off the handle and go into a rage, and so she had little presents like wrapped up super pretty and wrapping paper with bows and a little, plush toy or candy or something inside. She had those stashed all over the house. So no matter where they were, when her partner erupted, she would just grab one of these presents and boom, it would just change her in 10 seconds. She'd just be super happy that she got a present and she got to open it. And I just love stuff like that. So those are things that you can read about and learn about and help advise your caregiver partners how to incorporate that into their life when that starts being part of their relationship. All right, last thing is pharmacological management. Again, it's not my place to tell you anything about this, but this algorithm came out last year. And if you're doing this, this would be worth having in your clinic on a little laminated sheet or something. You can read the whole article. You can get it free. There's the URL down at the bottom of the slide. And just to help walk you through the different behaviors and some of the medications that might be helpful. And then also our Dementia team has had a couple of recent educations about this. And these screenshots of the slides are from our own pharmacologist, Trang. She gave a talk almost a year ago. Fantastic talk. If you look at this talk, you will have all the information you need to feel really confident in your prescribing for these kinds of behaviors. You do not need to be afraid of them because you've got all these tools that she tells you everything about. All right, that is the end of my talk. And I have no idea where we are in time. There we go.
We have about 15 minutes. And Karen, thank you so much for that wealth of information and truly on this really challenging topic.
So I can back out of my slides. I do have a couple cases. I don't know if we have time or if people have interest or if people have questions, we can just do questions. But the cases will be on the slide deck that you get, and you can just think about them yourself. And they're from real life cases that I actually personally know about.
I
So
think
oh, go ahead.
we could well, we could certainly see if at the moment there are any pressing questions or comments from the community, and we can hold for a moment the case presentations in our pocket and then maybe bring them out if time permits. So yeah, I'm curious from the community here, what especially spoke to you? What do you have a direct, is there a case that comes to mind that you may want to share? Is there an area that you have a question about? And of course, you can unmute yourself, say your name, and pose the question. You could also type it in the chat if that's easier, whatever you'd like. I know and imagine that, yes, Sylvia, I was just going to say, I know that we've all encountered these challenging situations. So Sylvia, please.
From my perspective, seeing this regularly, I would say sometimes people wait until the last minute to ask for help, and then it's really hard to avoid an ER admission, because if the person is feeling unsafe with the patient at home, you cannot necessarily force them to say, okay, then we start this medication. Most medications take time to kick in as well, and so do most behaviors. So in general, you know, in primary care, I would definitely probe for it. And in my clinics, I probe for it. So how is it going? Are there any behaviors? And I I don't put it as, are you agitated? I always say, well, if I had this, I hope I never had this, but if I had this, I would get pretty crabby. Does that happen to you? And so I try to reflect on them, and then the caregiver is probably more prone to say, yeah, actually, sometimes. And so you can just start teaching them the non-pharmacologic techniques way ahead of time so that they should be at least somewhat prepared. There's no preparation for this, but or nothing that you can say that will actually potentially, you know, cure this or make this completely better, but at least giving them the tools and the premonition to say, okay, this could happen. I would say there is never too early of a period. And the majority of people that come to me advanced is a disaster to try to rein them in fast, without a lot of other help other than the ER, you know, and few psychiatrists in town. So yeah, the sooner the better is what I would preach.
Thank you, Sylvia. That's super #1 take-home message.
Sooner the better. Thank you, Sylvia.
And you have to ask because people are mostly not going to offer it.
Yeah, and I mean, I think the other thing which perhaps Sylvia you're doing as well, and we need to consider, and you know, Laura Moscato gave a great talk at the Innovation Summit too, having that conversation with the caregiver alone and with the person with living with dementia alone to really make sure that you can have a frank conversation and asking those challenging questions. And I love, Sylvia, how you said, you know, if I had this, I would be crabby too. If I were doing all the physical and emotional and financial and practical caregiving in this, you know, ambiguous loss, as Pauline Boss calls it, I too might feel X, Y, or Z. And do you feel safe? And the firearm piece is also, especially in the state of Washington, so key. Kimmy, please share.
Yeah, I was just going to add to that, that providing any means of information gathering is so helpful. You know, just great caregivers who, you know, we provide questionnaires where people can just write concerns, and there's always questionnaires provided both to the person, the patient, and to who comes with them. So everybody's got their homework, everybody's writing things down. And that can be a private way to get information, or even saying, you know, if you want to send me a message or leave a phone message before the visit, and especially because often people will say, you know, I know this might cause a lot of anxiety during the visit, but having the just allowing that information gathering can be so helpful to make appropriate decisions during the visit.
Thank you. Yeah, that My Chart message or the follow-up with social work on the phone if they don't want to talk about it in the office, or filling out the written form.
I think Wendy
Nicole?
did a hand, or maybe that was a goof.
I think Nicole, has a
Oh,
hand.
okay. Oh, there's Nicole.
Yeah. Oh, okay.
Hi,
Nicole.
thank you so much, Karen. I was glad that you addressed the issue around firearms. I'm certainly going to dig into some of those resources you shared, particularly the one on how do you legally remove a gun from the home. We had a client situation a while back where we're care managers, so we work with people in their home. We are working with a client who had 24-hour care, and his caregiver found a loaded handgun in the closet. And this was absolutely not a situation where this client needed to be in possession of a handgun. The son, who was the power of attorney, lived out of state. My colleague called him to let him know what was going on, and he authorized her to remove the handgun from the house. She brought it to the fire station thinking they would take possession of it. However, they told us that either the gun owner or the person authorized as the POA had to physically hand them the gun. So it became this runaround, and the gun essentially became this hot potato that we got stuck with. And the only way to resolve it was the son had to fly into town, take the gun, and deal with it. So I'm just curious if anyone has had a similar situation or knows how, I don't know, if something got overlooked or if there's another resource for that.
Sammy, did you have your hand up?
Yeah, so Dr. Demoto Riley and Dr. Rhodes are doing this project with Garvey, and in that they have been interviewing different law enforcement. So we do have a little bit of insight on that question.
Great.
Law enforcement says that they generally can't serve as a repository for weapons. So their advice, what we've heard directly from the law enforcement officers, is that they recommend that if that is the case, someone purchases a gun safe for the home, especially if that person wants to feel like they still have the gun in their home. And then that person takes the keys and the methods of getting into the gun safe. So then the gun is safely locked away. The person no longer has access to it. They might still have the feeling of control of having the gun in the home, but then the gun is not accessible to them. And in a case like you're describing, where someone else has power of attorney, instead of them having to come in, and plan a trip specifically for this weapon, they can retrieve the weapon from the gun safe at a time that is appropriate and safe for them to do so, and then turn it into police. Or preferably, the police also were giving us options for having that sold or destroyed, because it is difficult for the police to just keep a large cache of civilian weapons on them. So that was kind of the advice we received from one of our law enforcement partners. But if anyone has any other advice, we are more than happy to hear it. And I hope that that's helpful.
Yeah, that's great. Very good to know. It's great idea.
Anybody else have any cases that they would like to share? Any questions for Karen or the team? So maybe in the last 5 minutes or so, if you want to bring up the first case as a springboard. I think you're muted, Karen.
Yeah, I can just show you the cases, and they could be used also if you have residents in your clinic or something, if you want to address this topic. So let me, gotta get out of that. Let me share screen. This one. And this. So these are the couple of cases that, again, true stories, shaded so that you can't recognize who it is. The first one is George and Monique. George, who's an 80-year-old male, he's a retired attorney. You have known him for 10 years in your practice, but you haven't seen him for 2 years. And he and his wife present today because she wants to fill you in on what just happened and to get advice. They've got an appointment at a specialty neurology clinic at the Academic Medical Center, but they couldn't get in. It's a 5 months away. And so what she says happened was that her husband, after he saw you at his last wellness visit, he had cognitive and emotional decline, and he wanted secrecy. He didn't want to leave the house, didn't let her tell anyone. So they'd been living with this with no care, no support, and he was just going downhill. And then last week he had become violent. He threatened her with a knife. She actually ran out of the house. She didn't have her purse. She ran out of the house. The car keys were in the car, and she drove to a motel, and the very nice motel owner let her stay for 3 days and let her come back later and play with a credit card. And he was home alone that whole time, but she was too afraid to go back. So she was physically unharmed, but it really woke her up that this was a dire situation. So she has come to your clinic today to ask what she's supposed to do. And so the case goes through, his history and all that kind of stuff. And then the wife's request of something to calm him down and control him while waiting for his appointment. So it's in your hands as the primary care provider to start tackling this. And she gives you a little bit more information about hallucinations and being very critical of her, and also having Othello syndrome and paranoia. So again, I'm not a dementia clinician, so I wouldn't expect to walk you through this course, but I thought you could noodle around with some of the questions that I put on here about, what kind of assessments are you going to prioritize today, and any prescriptions today. He hasn't been taking his prescriptions that you gave him a couple of years ago, but he's fallen through the cracks. You hadn't seen him. And any consultations or referrals. So that's the first case. And then the second case is Wallace and Akira. That's a 64-year-old widower, not yet on Medicare, which this is a problem, the people who are in between work and Medicare. And he has dementia, and his adult daughter lives with him, and has never been to a neurologist. He lives in a rural area. He doesn't have insurance, and he doesn't like doctors. And he had a mild COVID infection, and then his personality changed. He's being awake all night. He's being mean to her, pushing her, grabbing her, and choking her. And so she's called the police twice for the violent flare-ups. The first time they didn't do anything. The second time they actually witnessed the attack and pulled him off of her and handcuffed him. And their decision as the police was, do I take this person to jail or do I take this person to the ER? And she told them he had dementia. They went to the emergency department. And he was worked up. He didn't have any medical problems, and they discharged him home with her. And so now they're in your office. Sorry. Now they're in your office asking, what should they do? This situation is complicated by the fact that this father used to beat her when she was a child. So there's a long history of violence in the home, and also just her own demoralization of what am I doing wrong, and I can't take much more of this. And so again, same questions. How would you approach this in your clinic today, and what would you do? What can you do for these people today, and what kind of plan can you put together to get them the care that they need and deserve? So those are my two cases. And obviously we don't have time to kind of walk through them today, but those are what I came up with. Again, real cases. The 3 days in the motel, it's a real thing that happened to somebody I know. So yeah, I don't know what you see in your primary clinics in terms of this kind of behavior, but as the population is graying, and as the healthcare system gets more bogged down, and rural-urban divide, I'm really happy for Echo Dementia to be reaching out to all of you in areas where you feel like you need to be more on the front lines of helping these kinds of families.
Yeah. And as a trusted, caregiver in primary care, somebody they know they can go to and trust. And I think in the last moment, just really having this top of mind that safety is so foundational, and partnering with first responders. And we'll look forward, Kimmy, to what you have to share, the work with the Garvey, and just really making sure that we're caring for the caregiver and the person living with dementia, assessing early and often, providing those ways to convey that information, asking. And so we are at time. This has been a fantastic presentation by our own Hub team member, Karen. Thank you so much, and for your candor, and for your, really doing a deep dive today with us. And please fill out the 1-minute questionnaire. We do want to hear your thoughts and opinions. It matters very much to us. And happy Pi Day, and we'll see you in 2 weeks.